This is a presentation discussing the synchronization of magnetic and electric fields on the 272B and a discussion of concepts of electrode placement for the electric fields for the EM272B. The development of this device really created some thinking out of the box. Once we were able to create it, then we could clinically test it, and it has certainly proved that it's been extremely effective. The EM272B essentially is a magnetic converter and an electrical skin stimulation in one box. There are two magnetic discs that can be run into pairs of skin electrodes that can be run off the same unit. This is hooked to software on a PC computer. This unit allows the synchronization of magnetic and electric fields. That is, we can take a pulsing electric field that's transmitted through skin electrodes and synchronizes to 1, 2, 3, 4, 5, 6, or 7 of the magnetic inductor coils on the magnetic output. The software that runs this is run on a PC computer. It's called the pulse frequency EM272B. This will be discussed in other software, but this software allows you to view the frequency files that you have loaded onto an EM272B. It allows you to view all the magnetic frequency files that are in a file bank. It allows you to load these frequency files very efficiently and rapidly to the stimulation unit. It allows you to create new magnetic files, allows you to edit magnetic files, and allows you to create and play magnetic files. That is, you can put a line of frequencies in and then play it immediately to see what kind of biological response you might have. There also is a complete memory of all patient files with the frequency programs that you've generated for those patients. A frequency file, for example, would look like this on the 272B. This is a 3-line program. First line is basically a concussion type program, and none of the frequencies in this line are synchronized to skin electrodes. You can make the skin electrodes any frequencies you want, separate from the frequencies you put in for the magnetic inductor coils. Second line is a Schumann resonance harmonics, which we like, but we're running skin 1 and skin 2 to the primary effects that we want to achieve in this specific program. And line 3 is where we synchronize channel 2 with skin 1 and channel 4 with skin 2. This allows an emphasis or significant improvement of that signal in the tissues themselves. This is a program that's based upon the work of Carol McMakin, where she designed 2 frequencies that are played on 2 separate electrodes, in this case skin electrodes. We've taken those programs and we've created a 7 inductor coil program with 2 skin electrodes. So we take the concept that Van Gelder had developed for structure and function. We take the work that Carol McMakin had done building some of these programs. We put them together in one device. In this case, channel 1 and channel 2 are synchronized to skin 1 and skin 2. So every line on this program has a skin frequency that's resonating with a specific magnetic inductor coil. And you can see with one set of skin electrodes runs 4 magnetic inductor coils. The other skin electrode runs 3 inductor coils, all running the same frequency. The magnetic converters for frequency generators basically were developed by PEMF Wellness to take the output from these frequency generators, convert them into a magnetic field. There is no electric output that comes from the magnetic converter. If you want an electric output, you must have a second frequency generator, but that second frequency generator, it's not synchronized to the magnetic field. The frequency generator for the EM272B, which generates both magnetic and electric fields, has the capability of synchronizing the electrical impulse with the magnetic impulse. And it also allows you the option of linking the skin electrodes to as many of the magnetic inductor coils that you want. In brief review, why synchronizing magnetic and electric fields may have some significance is that it certainly enhances the tissue response. Remember, electric fields induce, electric skin pads, I should say, induce electric fields by a potential difference between electrodes. The strength of the electric field is dependent upon the tissue type. That is, different tissues have different permeativities. The electric field is reduced the deeper the signal penetrates into the body. So you can have a superficial fascial membrane, which has quite a strong signal, but a very deep fascial membrane, or even a bone, has a significant lower signal density. Whereas a magnetic field penetrates through tissues evenly without any reduction or no significant reduction in the field strength. It's important to recall Faraday's law, which you probably were never taught in medical school or professional schools. Faraday's law, which basically says a changing magnetic frequency or changing magnetic field can induce an electric field. So as we change the magnetic fields through the pulses in the tissues, we actually induce an electric field. If that electric field is in synchronization with the electric field that we create through electric pads, we have an enhancement of that electrical signal. In this case, you can see that the start of the magnetic pulse with the red arrow, the scope reading on the left, compared with the scope reading on the right, which is the electrical signal. Both signals are starting at the same time, which enhances the electrical signal in the respective tissues. Electric fields induce electric currents in tissues by a polarity. So a non-alternating signal, which is basically running all in the same direction, is essentially a square wave that induces the electric field in a tissue. Again, a magnetic field, a changing magnetic field creates an electric current that interacts with tissues, particularly ions, dipoles, and membranes, which the electric field that's generated by the skin electrodes also works through the ions, dipoles, and membrane potentials. But the beautiful thing about a magnetic field is that it penetrates without signal loss, and at any tissue it converts the changing magnetic field into an electrical field similar to the field that's generated by skin pads. So when you think in terms of current flow, electric fields, we have a non-alternating electric field and an alternating electric field. Whereas in a magnetic field, it's the alternating and the non-alternating occur basically in the same signal. So the concept of alternating and non-alternating does not apply to pulse magnetics. Alternating, non-alternating electric fields in the FSM, the MEN, the HOW RT, and the EM272B are basically all the same. On the EM272B, however, you can see in real time each frequency that's played in the 7 inductor coils, and you can also see the 2 skin electrodes that are being played. Further down that line on the skin electrode frequencies, you have a letter A/NA. A means alternating, NA means non-alternating. And you can change the alternating to non-alternating in the mid portion of a program by taking the current level down to 50, clicking the down button again, and it'll change it from alternating to non-alternating or non-alternating to alternating. Again, briefly, skin electrode placement. One very fundamental cardinal rule. Red is positive, black is negative, red is to the head. As a medical student in 1970s in medical school, I worked with my medical school advisor was Robert Becker, who I actually worked with in his research lab. He was studying tissue regeneration in salamander, and one of the things we were doing was measuring the electrical potential on the surface of a salamander. As you can measure this on a human too. You'll see the positive signal is closer to the spinal cord, the negative signal is further out to the periphery. So when a pathology hits a limb, either nerve or tissue injury, inflammation, it actually changes the electronegativity on the limb, makes it less electrically negative. So if we can create the normal milieu or the normal electrically negative environment peripherally, we can hopefully change some of the pathology. So here's the cardinal rules for setting the current path. The red pin jack is always at the origin of the nerve. This is the positive lead. So for example, in a sciatic case, it either would be right on near the neuroforamen or where the nerve root exits through the spinal cord. Peripheral nerve impingements, we always put the red electrode, the positive electrode, proximal to the pathology. The black pin electrode is always distal to the pathology in the sense of a sciatica. We put it on the foot, or in the sense of a peripheral neuropathy, distal to where the neuropathy or of a pathological lesion, distal to the pathological lesion. Joint pathology, we've tried both alternating and non-alternating. The general rule we followed with good success is we put the red pin, that is red to the head, proximal to the joint or the area of pathology, and the black pin, negative, distal to the joint. Sometimes we cross the leads and sometimes we don't. Here's an example of sciatica. So we're putting the red leads against the spinal, in this case against the spinous processes. In this case, we're also put the two magnetic discs on either side. So let's say they have a more of a SI issue, or they have arthritis in the lumbar spine, as well as a sciatic. We'll treat the lumbar locally with the magnetic, but we'll also synchronize the magnetic with the electrical and put the distal electrodes on the foot to reestablish the normal electronegativity of the distal extent of the sciatic nerve. Very, very effective. We have patients take these units wired to their bodies home. We have the stimulator unit put on a little belt buckle, which is carried like a cell phone. And we've had really good success for, documented sciatic symptoms where you have profound neuroforamen narrowing or absolute frank disc herniation. On joints, we sometimes run alternating and sometimes non-alternating. In the rotator cuff, for example, we'll cross the joint or not cross the joint. Red always proximal, black always distal, and we'll put the magnetic inductor coils both the front and back. So the magnetic fields actually cross inside, and the electric fields and the magnetic fields are enhanced when we harmonize the signals. A knee is very similar to a shoulder. Remember, red is proximal, black is distal. Same principles involved. If you have a peripheral neuropathy like a cubital tunnel syndrome of the ulnar nerve over the medial epicondyle, we'll always put their red electrodes proximal and the black electrodes distal, and then the two magnetic discs will be over the elbow joint itself. And then if we're dealing with a myofascial, thoracic, or lumbar dysfunction, I like to use a non-alternating electric field. So we're running the electricity down, but we're enhancing it by placement of the magnetic coils. Pelvic floor dysfunction was an interesting issue. We've had a couple cases, particularly with the problems with the pudendal nerve. If we run the black distal at the end of the pudendal nerve and the red on the lower lumbar spine, and then we run two magnetic discs, we have a fairly good clinical result for this great major contributor to pelvic floor dysfunction. The other area I found interesting is on breast reconstruction surgery after patients who've had significant radiation therapy. They'll have a huge amount of scar tissue between the skin and the muscle layer. As you expand the tissue with the tissue expanders, it's an extremely painful process for women who have had a lot of radiation therapy. So we designed a program running the electrodes in the bra and crossing the electrodes, red proximal, black distal, and then we'll put the magnetic pulse that's synchronized to the skin electrodes, and had really good results. You can do the same thing with a peripheral neuropathy such as a carpal tunnel. There's a simplistic concept, red proximal, black distal. We'll also put the magnetic disc over the nerve itself at the transverse carpal ligament. Lastly, we've had some questions. What does the pump mean? Because you see on the software we have a thing called the pump frequency. A pump frequency allows the turning off and on the output by a second lower frequency. So let's say we take a line of frequencies and we want to stimulate a delta or a theta wave pattern on that. We'll run that 1 to 8 hertz. We can pulse all those frequencies with a second frequency. So it's like putting two frequencies together. In this program, you can see we use an alternating polarity, 100 microamps, but in this case, the pump is 0. The default on all of the programs we have in the EM272B, the pump is defaulted to 0.0. But we've had some good success by running 3 hertz, 2 hertz, 7.8 hertz, and pulsing, let's say, inflammatory frequencies at that with those frequencies. And lastly, there are many ways you can put skinny electrodes on. Technology that I developed with working with Dr. Becker in the 1980s and 90s, we used silver nylon fabric basically as a means for wound healing. We also used it as a means for putting a wide dispersion of an electrical signal. Carol McMakin got some of these electrodes in the early around 2000, but had to discontinue because there was too much patient discomfort. We designed a 272B so it could accommodate these special electrodes that basically have to be handmade. If I have a complex peripheral neuropathy with multiple neurologic injuries on an extremity, let's say a crush trauma to the upper extremity, I will run a sleeve and make that my black electrode, and then put my red electrodes up in the shoulder or on the spine itself. But the regular TENS electrodes work in most cases. Thank you.